Hello, everyone, and welcome. Thank you for joining today's webinar, a conversation with Laura Shaver and Reija Jean from the BC Association for People on Opiate Maintenance. I would like to begin by acknowledging that today's webinar is being broadcasted from the unceded traditional territories of the Lekwungen peoples, now known today as the Songhees and Esquimalt nations. My name is Rebecca Erickson, and I'm a policy analyst at the Canadian Mental Health Association's BC division, and I'm joined today by my colleague, Tanis Oldenburger. If you'd like to introduce yourself.
Hi everyone, I'm Tanis. I'm a 32-year-old heroin addict and I use she, her pronouns. I live, work, and play as an uninvited guest on the traditional unceded territory and spiritual realm of the Stalo Coast Salish people, or people of the river, here in Chilliwack. I have over 15 years of experience living with concurrent mental health and substance use disorders. I've been working this past year with the Community Action Initiative, interviewing and collecting data from CAT teams across the province. I got to join CMHA and PHABC on the ODPrep project, where I got to meet and interview more amazing organizations and drug user groups practicing overdose prevention and response across BC. These webinars are here to encourage connections amongst our incredible network of lived experience experts, and I feel honored to be part of these conversations and community. Thanks, Rebecca.
Thanks, Tanis. So we will be your host for the next 90 minutes or so. And to start us off, I would like to point out a few features of the GoToWebinar platform and quickly run through the agenda. So first off, there are two options for sound. You can listen with your computer's audio, or you can dial in by telephone. If you find that you're having difficulties with one audio option, you can switch to the other at any point. If you do choose the telephone option, either use a landline if you have one, or turn off the output on your computer speakers to prevent the awful feedback noise. We will be recording today's session and posting the video online at the CMHA YouTube channel. I will copy that into the chat. It's youtube.com/CMHABC. And today is our final webinar in our seven-part overdose prevention and response webinar series. So I encourage you to go check out our previous webinars on the YouTube channel as well. They cover a range of topics, everything from peer-led initiatives to low barrier shelters, episodic overdose prevention services, empowering communities to take action, and more. There are also resources from our presenters available for download in the handout section of the panel to your right. The format of this webinar is to have what we call a fireside chat, which is an informal conversation between our two presenters from BCAPOM, as well as the audience. So we encourage you to ask questions throughout the session. If you have a question, please type it into the questions section of the panel to your right. We will collect them throughout the webinar, and Tanis will either read them out to the presenters during the presentation if they're related to the topic currently being discussed, or at the end during the Q&A period. If you would like to address your question to a specific presenter, please make sure to make a note of their name in your submission. So before we introduce our presenters, I would just like to share a bit about the ODPrep Knowledge Exchange series for those who are joining for the first time. Today's presentation is a part of our Overdose Prevention and Response Essential Practices, or ODPrep, Knowledge Exchange webinar series. The project is a partnership between the Community Action Initiative, the Public Health Association of BC, and the Canadian Mental Health Association BC Division. The project began in early 2020 and aims to identify unique practices in peer-led groups and community-based organizations to address overdose and poisoning prevention and response, as well as showcase and share these essential practices, and finally, to collect that information and the innovative findings to advance policy at a systems level. As a part of this knowledge exchange project, we have also created an online learning community. So this is a space to continue our conversation, connect with one another, and share resources to improve overdose and poisoning response and prevention efforts. I will copy the URL into the chat if you'd like to join and be a part of our community. I will now pass it off to Tanis to introduce today's webinar.
Hi, everybody. So today we will be featuring the president and vice president from the BCAPOM. So since 1997, the BC Association of People on Opiate Maintenance, previously the BC Association of People on Methadone, under the umbrella of VANDU, has been supporting people who use drugs to access life-saving opioid agonist therapy programs and advocating for the rights of people with lived and living experience to lead in the development and implementation of these pharmaceutical alternatives to the toxic drug supply. In this webinar, Laura Shaver and Reija Jean from BCAPOM will discuss the origins of their organization, their advocacy during the pandemic rollout of safer supply, their process for supporting and uplifting people who use drugs, their values-based way to partner with institutions, and their visions for an expanded network of advocacy and access to opioid agonist therapies. Join to listen, learn, and contribute to an interactive dialogue today. So first, I'd like to introduce Laura Shaver. Laura Shaver is an experienced drug user activist and organizer. She has won several awards for her work in the Vancouver's downtown East Side community where she resides. She is the president of the BCAPOM and lead peer advocacy navigator with the BC Center of Substance Use. She has been the president of the Vancouver Area Network of Drug Users in the past and continues to sit on the VANDU board. Laura has been instrumental in several direct actions to improve conditions for people on opioid maintenance, including a class action lawsuit against the province of BC over clinic fees and advocacy related to BC's methadone formulation change. Reija Jean is a writer, activist, and organizer living in Vancouver, BC. As a person on OAT and a member of the BCAPOM board, she uses her skills and experience to help improve healthcare for people who use drugs. As a peer and person with lived experience, she has collaborated with many organizations, including the BCCSU, the BC Patient Safety and Quality Council, and Healthcare Excellence Canada. She also sits on the Crackdown podcast editorial board. Thank you all so much for being here today, and I will now turn the floor over to BCAPOM.
Do you want to introduce? My name is Laura, so I'm the president of the British Columbia Association of People on Opiate Maintenance. I saw when we were first being introduced that it said I was a co-founder, and that's actually incorrect. I've just been a part of the organization for a very long time. The co-founder is actually Dean Wilson, who was instrumental in the first OPS being unsanctioned. So BCAPOM is a group of people on opiate replacement therapies. So anything from methadone to injection, heroin or morphine. We used to be just the British Columbia Association of People on Opiate Maintenance, but on methadone. But now that there's so many other prescriptions, we've expanded our group to involve all the different prescription medications.
Yeah, we've expanded our reach. So basically we deal with prescriber models in BC. So Laura, the first question I have for you is, okay, so you're not a co-founder, but you've been a longtime member and BCAPOM president for many years. You've been a coordinator for the group for many years. Can you explain, and you already did this a little bit, but can you explain a little bit more about what BCAPOM is and why we are so unique as a group?
So BCAPOM is a group of people that are current or former drug users, which mainly focuses on the opiate side of drug use. I think I think BCAPOM being part of VANDU is something that saved my life, and the reason I feel that it's so unique is because it is run by all current drug users. And we are the ones that make the decisions to how our group runs, the things that we that we that we look at, that we follow, or that we fight for. Before I came to Vancouver and BCAPOM, I was just lost. I was a person who went to see a doctor who was on at one time 270 mils of methadone and got cut down to 50 mils of methadone and was like, okay, like, what am I going to do about this? Feeling like I had absolutely no power over my life because of a prescription that I was on. A doctor was able to tell me what was going to happen. And if I went to a different clinic, that doctor could have told me a totally different thing. So I thought I joined BCAPOM so that I could help and try and rewrite policies that were designed to serve us so that another person didn't go through the same feeling or the same action of having a doctor being able to tell you whether you're actually going to live or die. Because can you imagine being on 270 mils of methadone and them giving you a 210 mil drop and having no power over that decision?
It's crazy.
That to me, it was terrifying.
Yeah.
And it's what kept me up for nights before. And it's the reason why I'm here and why I think BCAPOM is unique, because we have already been able to change policy.
So it's interesting that you say like BCAPOM is a group that is run by current drug users. Now, when you say drug users, are you meaning opiate antagonist treatment consumers?
Yes.
Just to be clear.
That's what I mean.
Okay, because I think, yeah, because I think sometimes like it can be a little bit confusing.
You might be a poly. Yeah.
Yeah, you might be a poly substance user. You might still be using street fentanyl, but our aim is to deal with the clinical side of your medication. So, you know, these drugs are supposed to help us, and they all kind of help us in different unique ways. And maybe they don't help us in ways that they were originally intended to, but they still help us nonetheless, right? So there are people who just use their OAT, like say their methadone, and then there are people who use methadone and then top it up with fentanyl because the methadone just isn't cutting it for them. And there's various scenarios, right? And we don't really care as long as, you know, if you're coming to the group, you're on some sort of prescribed alternative.
Mm-hmm. And the thing is it's a group that's open to exactly like Brian said, and it's focused on prescription opiates, because it's to me, I found that it was still unfortunately a hustle, but a different kind of a hustle.
Yeah.
You have to find a different way to navigate your treatment. It's like, you know, how you have to, you know, hustle to get your street heroin or fentanyl. You have to doing the same thing, doing the same thing, but in a pharmaceutical way. So you have to learn how to do the same things, but with doctors and policymakers. And to me, I guess that's the easiest way for me to describe what BCAPOM is. It's a group of all different kinds of opiate consumers, prescription opiate consumers, that have unique and different, I guess you could call them problems with doctors, that we try and to identify and discuss with each other. Because the difference between somebody being able to go to a doctor's appointment with you and get you on an opiate replacement could be the difference between whether you're alive the next day or not.
Yeah, totally. Yeah. Yeah, I think that's really an important distinction to make, and I think that is why we're so unique. You wouldn't think that prescription drug from a doctor, like let's say I have diabetes, that I would need an advocacy activism group backing me up. But with the OAT system, for those who aren't familiar, I found the same thing, right? And I do think BCAPOM is unique in that way, where we are one of the only groups who's kind of willing to talk about it. I feel like methadone, Suboxone, Cadian now, all of these alternatives, but really, I think it started with methadone, really have been given a bad rap, and a lot of people still think that it's replacing one drug with another. I mean, maybe it is for some people, maybe that's how they survive, but there's a lot of misconceptions about it, and there's a lot of stigma and just sort of negative, like it's like people don't want to talk about it. So BCAPOM is really one of the only groups that I could find when I was struggling with feelings of shame, feelings of not wanting to be on the medication, where I could actually go to a group and talk about my feelings and meet other people who shared similar experiences, right? And also showed me how to survive.
And that's the thing, is that it's one of the things that I learned, and I hope that BCAPOM can help other people with, is normalizing what we do, normalizing that, well, drug seeking, but it's my body, and why am I not allowed, and why shouldn't I be allowed to do it? It's okay that there's 4 people a day dying of an opiate overdose, but it's not okay to be on a medication to stop that. So that's the thing, is that now there's so, one thing is that it's weird to me, because there's so many different medications to quote stop an opiate overdose or to stop an opiate withdrawal, but it depends on who you are, what clinic or what doctor you go to, depends on what medication you're allowed to access. And that, to me, seems like just fucked. If you're going to have the medications for us, then why can't we be prescribed them? And if you're going to make a program for people, then the people the program is made for needs to have the people that they're making it for design it.
Yeah, totally. And I just really think it's so weird, because obviously the people who want to restrict these drugs from us, or restrict like dosages, right? Oh, you can't be on this high of a dose. They don't have any experience on these drugs. They don't know what it's like to be on methadone, right? I was on Suboxone for a long time. I didn't know what it was like to be on methadone. I switched to Metadol D, and honestly, I feel clarity in the same way that I did on Suboxone, and which means that I feel clarity in the same way that I did before I even started OAT treatment. Like, I'm not impaired. I don't feel impaired. I'm on a stable dose, and so I really feel that there's a lot of there's a lot of fear mongering and just
you are very lucky that you have got that. What you just said to me gave me goosebumps, because you know what, there are so many people that never get to where you are, and that's why what BCAPOM, to me, you are
I have a good doctor. That's why.
Story.
Yeah, I have a good doctor. That's
but you
why.
Have a conversation with your doctor. Is you. That's what, like, how I feel and is important, is that you are able to have a conversation with your doctor to get your treatment, and that's what BCAPOM can do and does.
Yes.
And what we do You're not afraid to go to your doctor and talk to them about the treatment that you should be on or that would fit you. They may when you go and say this is what, well, no, but you don't know because you haven't done it.
No.
And the thing is that sometimes, or lots of times, we know guidelines and policies about our treatments better than they do.
Exactly. Yeah. And like the idea of me going to my doctor to increase my dose so that I can like feel high, like just doesn't even like seem like that would be like a worthwhile thing to do. You know, like if I want to feel high, I'm going to go out and use other like street drugs or just other drugs, not my medication, you know? I don't know, because it just doesn't feel like it would even make me high. If I was on too high of a dose, it'd probably just make me more tired, you know?
See, and that at the beginning when I started, that's what I need. That's what I wanted. It's what I needed. It's just because I was trying. I wanted an opiate replacement. I didn't want to have to use heroin or go out and hustle all day to make money. I wanted to do it, but I wanted to do it without having to have all of the stigma and negativity with it. Because to you, you don't. I use the medication that the same medications that you're taking in a different way, and that conversation or things that we can do here, and it's okay. Because for me, maybe I want the doctor to prescribe me a safe supply because I want to get high from it. But and then and we can have conversations like that. It's just like how you just said that you want to be on these medications so that you don't feel that. If you wanted to get that feeling,
unless I want to, and unless I choose to go out and do that, right?
And that's the thing, is we're supposed to be able to, we should have choice. There should be choice of what reason we're doing the opiate replacement therapy or consuming an opiate. So it even, even the terms of opiate.
Did we lose Laura?
Yeah, I think so. Is your camera back on?
Yeah. Everybody, are you back? Are we back together?
We're back.
Okay, so you talked a little bit about what drew you to BCAPOM and what, but what has motivated you to stay involved over these years? Like, how many years have you been involved?
So now I've been involved with BCAPOM now since 2007. No, 2008 is when I really started to be part of the group. What's kept me here is that I was able to be part of a group that made a policy change. We won a major class action lawsuit that changed policy for all the people that were on opiate maintenance on social assistance in BC. Meaning, like, when you get to actually see something change that affects that many people, it's uplifting. And when people stop you on the street and say like, hey, you're the one who did, thank you. And it's and the thing is that it wasn't just me, it was a group I belonged to that did this. It's BCAPOM as a group. It's everybody that's on an opiate replacement that won that lawsuit. That was we as a group and as people got the government to change something and have to pay back millions of dollars to people, quote, that are drug users. Well, guess what? We are now doing a second class action because I didn't realize until I was on an opiate replacement how criminal the system actually is. And like I was saying earlier, science fiction now to me seems like history movies. The things that have happened to us, like, people are are disgusting. Paying off, like actual knowing that things are actually happening, and knowing that, like, people watering down medications that you take. What the fuck is that? Are you serious? That's
insane.
How can that stuff happen?
Yeah.
And it did. Part of BCAPOM at the beginning, a fight started that there was 2 hotels that somebody owned, that if you were on methadone, you couldn't live there, or if you were on methadone and lived there, you had to go to their pharmacy, see their doctors. Like how does a system let that happen? I didn't
Exactly.
understand it, and that's here is because they're dope dealers in a different way. So then what's wrong with what a street dealer or just consumer does? So to me, it's like when there was a safe supply line, some of the media said there was more organization and you know, respect in a line of people trying to pick up safe supply, so an illicit substance, than there was a line in the fucking food bank.
Yeah, exactly.
It's and like and that's the thing, that it's not fair for people
crazy.
to get into a group or into a, because the truth is that, you know, I think everybody, if you got to actually have the experience of being a drug dealer, you would see how many people in this world are hiding things. The difference between them and me is that I don't lie about my drug addiction or my drug consuming. And that's the thing, is that BCAPOM shows me that it's okay to be that.
That's right.
That it's okay, that's not wrong, and that there's other people that are in the same boat, or would let, that can't or don't feel the same, or aren't able to do the same thing that I can. It's like I was saying earlier, somebody that contacted me from Nova Scotia this morning asking with help for a doctor in safe supply, and it's like, what? They don't even have a doctor there.
I know.
And they don't even have that doctor, not one doctor for a whole fucking town. And that's why I'm still with BCAPOM, because that we need to expand. We need to help people to be able to get that going. We need to make it so it's policy in every province, in every city, every country, for somebody who, if they are on a illicit substance and want to get up, or just want maintenance help with it so they don't go through a job, that they can.
Well, and that's the thing. We need to educate people and educate prescribers that there's different ways that people are using OAT medications. And one of those ways is to maintain so that they don't have to go through withdrawal if they don't have their supply that day, or if they weren't able to hustle and get enough money, right? At least they're not in withdrawal. They have something that's carrying them through the night, hopefully, right? And that's something that's really not been, I think, popular with doctors, because their narrative, the way they've designed it, is that they really want to see these drugs replace the illicit drugs, and everybody stops using and everybody's abstinent and they go off into the sunset, and then somehow maybe they taper off of their Suboxone or their methadone or something. Like,
so they'll prescribe you the medication to be addicted and every day, but they
dependent.
Exactly, to be dependent on it, but your then it's not good to be dependent.
Exactly.
Why would you have this job if you don't like what you're doing?
And I kind of realized very early, like I was on OAT for the first time, Suboxone, in 2017, and I was at a private clinic, and I realized very early that, like, okay, this is going to be a long ride. This is not going to be just something that I'm going to be able to hop in and out of, and just like, okay, I'm done with my drug problem now. Now I'm just gonna go back to normal life, right? So I really had to find this group. My survival depended on this group because I had to fucking talk about it. I had to talk
when I
about it.
started when I started
Right? Like
23
I had
years
to
ago,
get it out of my head. You know?
They told me that I would be on methadone no longer than it was only no longer than a 5-year period. That it was just a program that was, and I'm into it 23 years now.
Yeah. Yeah. Yeah.
The thing.
It's
like,
maintenance. It's maintenance.
Yeah.
For a lot of us, it's maintenance. It's like you jog every day. It's like if I do my yoga, it's if I have to get sleep, if I have to get up in the morning and take my medications, if I have to eat, if I have to take my OAT, that's all maintenance. That's maintaining me to be able to go out into the world and to do the work that I want to do and that is needed and that no one else is doing, right? Except for our group. Yeah. Totally. So can you explain a bit more about how BCAPOM helps people on OAT in this province?
So, there's one thing I think it's one of the best things that happened, but it pisses me off is that I got because of BCAPOM, I was able to get a job at the BC Center on Substance Use. That I got a picture on it taken that says Province Health, St. Paul's Hospital on it, which made when I walked into a doctor's office with somebody different. So this is what BCAPOM is been able to do, is we're able to walk into a doctor's office with somebody and help them to get on an opiate replacement medication or a safe supply, which is maybe you're drug seeking. Well, so what? That's what a safe supply is supposed to be. It's supposed to be a safe supply of an illicit drug.
Yeah.
And that is something that BCAPOM is trying to help educate doctors with. That it's education.
Yeah.
It's sometimes we're not supposed to know the guidelines and policies of the opiate replacement therapies better than the doctor. And that's the thing. That's what BCAPOM is good for, is to educate the people that are on the medications about what their rights are as an opiate replacement consumer.
Yeah.
Is that answer the question? Is that we can educate and help people to know what the drug that they're on or the prescription that they're prescribed, what they actually should be able to do with it, or how it can be consumed or used. I hope I'm not confusing people by what I.
Or maybe you need, maybe somebody is having trouble and they need to switch their medication, right? And they need some advice for how to talk to their doctor about doing that. Like, hey, I think Cadian would be a better fit for me. Maybe I want to try that. Maybe I'm afraid to talk to my doctor about it because talking to your doctor about your drug use is not a comfortable thing unless you have a very good relationship with your prescriber. Like, and so it's like, what do I say, right?
Yeah.
How do I ask?
And see, everybody is different. That's what, when I first came to BCAPOM, that's what the people that were on the board or the things, that's what they showed me how or made me feel empowered so that I could find my own way to do it.
Yes.
So that's what that's why I am part of BCAPOM, is because I want to make it so that you can have a conversation with your doctor about what is right for you, whether it's
Yes.
prescription heroin, or whether it's a prescription of a benzo medication, or
Yeah.
or a, how do I get off of this medication, or how do I take care of a pain that I
Yeah.
have with the medications that are available for me, without
Yeah.
me feeling like if I do that with you, I'm gonna lose my job, or I'm
You're
gonna
gonna
be,
report me. Yeah.
or you're gonna report me. Because I remember there's one time that somebody came in to me and wanted to make a complaint because they were told that because they were on an opiate replacement therapy and drove a car, that they were going to alert ICBC,
Yes.
ICBC about it, and have their
Yeah.
license taken away because they would be impaired.
And that's something
Can you
that's coming back
believe
around again too. That's something that that we're hearing about again. So these are the kinds of
that? And
issues
the
that
truth is,
we deal with, right? Yeah. Yeah. Because it's unfairly targeting people on methadone specifically. So so that's just an example of so that's an example of things that come across the the BCAPOM office, the desk, that we start hearing things, and it's like, and then we have to track it down, like, okay, so what is this? Is this actually a policy? Where did this come from? Who's saying this, right? Is this something just doctors are kind of like, is this a rumor? Are they reading the
and so we
shit
checked.
correctly?
Sorry.
No, it's
And so
okay.
I checked it out. And that's the thing, is that there's people that with BCAPOM that are willing to look into these things to see
Yeah.
if they have the right to do that. Well, they don't have the right to do it, but the thing is they can.
They
It
can.
actually is
Yeah.
real policy.
Yeah. They can if they believe that you're a risk of impairment.
Because
Yeah.
you're on an opiate replacement medication.
Yeah.
So I
Yeah.
had a conversation with the person and doctor about this, saying like, this is this person's job. Their job is a driving job.
Yeah. Yeah. Yeah.
If you do this, you're not only you're ruining their life, you're
You're taking away
changing
their livelihood.
you're changing their access to a job, because
Yeah.
you're making the decision that this is how that yeah, it's wrong, it's unfair.
It's
There
wrong.
are people who have to drive to get their medication because they live so
Yeah.
far away, but it's illegal to do it.
So what are
There
you
are
gonna do
people
about that? And then just the
that have to do
amount
with
of
carries,
and
not
then the
being able
amount, like the amount of people in this province and in this country and in this world who use drugs, like most people use drugs, right? So, but most people are not being diagnosed with a substance use disorder. I'm sorry, but people working in Fort McMurray or whatever, people who are partying on the weekend hard, drinking, people from my hometown where drunk driving is a very common thing, like, they're not targeting those people, right? Unless those people actually get into an impaired accident, right? But they are unfairly judging a person on methadone as being impaired, even if my driving record is clean. Like it's like, it's fine. I've not gotten into an accident. I'm fine. Right?
And that's where the thing that BCAPOM is, it gives it so that there are people that come from all different types of situations.
Yeah.
And we can talk about them and try and find
Yeah.
a way to make it so that these things don't happen. So like, you know, it's, I don't know how many doctors are watching, so I'm not saying some stuff. No, I'm just joking. That's the thing,
Well,
is that
it's just,
it's not supposed to.
it's
We're not
another
supposed to have
example
to
of
feel like that.
it's another example of something we have to go to bat for, right? And we're a group of patients that really have to go to bat for these kinds of things a lot, right? And so we really have to be on top of what's going on, and it's important to hear that from our members. What's going on with you? You know, what's going on with your doctor? You know, how can we make this better? How can we reform the system in a collaborative way? But Laura, you touched on something earlier that I really wanted to ask you about. Now you're talking about your advocacy style, right? So what's your advocacy style, and what are some challenges that you've encountered in the past? You know, for example, a prescriber who won't prescribe a safer supply medication to someone on OAT, right? How would you sort of tackle that?
I guess my style has been is that I research what the guidelines and policies actually are, or what there is available to somebody, so that when I go into a doctor's office with somebody, or am on the phone with a consumer, that I know what I'm talking about, that I know that I, you know, can explain for or advocate for somebody how important it is for them to stay alive to have this medication.
Yeah.
And that this person is coming to you to ask for your help for something to keep them alive.
Yeah.
And you have the ability to do it. It's this person that I'm talking to, their job that they have chosen is to give these medications to people.
Yeah.
So that's why. So that so just so my style is showing a doctor that there's somebody else there, that there's somebody else supporting this person, and that they're not alone. They're not the only ones that are doing it, or that are looking for something, and that these things are out there. So we need to be able to have access to them. What's the point of an opiate replacement program or therapy or maintenance if we can't take them? And that's what my style is trying to have a doctor or a pharmacist see the person that they're prescribing to as a person, and not as a drug user. Because so what if they are, but your job is to give them a maintenance or something as a drug consumer. Well, so it's I'm not afraid to talk to a doctor about, so I'm not afraid to talk to a doctor about somebody else's drug consuming, or that their medication they're asking for can affect them and could maybe quote make them be a more productive person in society if you did prescribe them this safe supply as opposed to this one. Or how trying to get it to understand that prescribing somebody, this is an example because people that are on opiate maintenance are a lot of times poly users, a pill for a smoking addiction. It's not realistic. It's just it's me being able to go to a doctor and saying, you aren't walking in this person's shoes and are not prescribing them the right sauce to put on their burger type thing. It's being able to educate it's being able to educate doctors is what is what I think I can do, or that I do, is telling them that what their job is.
Yeah.
Kind of what it is because the thing is that unless you are actually a person that's gone through an opiate withdrawal, I don't think that you will ever be able to actually prescribe somebody a proper opiate maintenance withdrawal management medication.
You'll never understand. No. Yeah, I agree. And I would say that, you know, my style is similar to that. And I've definitely learned a lot from you, Laura. We've been working together, you know, for about 2 years and, you know, in a much closer capacity over the past year, I think. And, you know, I've learned a lot from Laura. And I would say that, you know, my thing is right. So making sure that I have the guideline on hand, right? And so that I can say, oh, well, wait a minute, but it says this here, right? So what does that mean? You know, so I kind of asking them questions that I already know the answer to, right? So that's one of my kind of techniques. And then the other thing that I can do is I can take notes for the person, right? Because the person is, this is a drug that potentially, if you don't take it every day, you're going to be in extreme amounts of pain. So it's a painful situation. It's a scary situation. And there's a lot of emotions. There can be a lot of emotions, right? So it's very hard for that person to stay on top of everything that they need to ask, right? So I can kind of like remind, I can say, okay, and we also wanted to ask about this, right? We also wanted to ask about deliveries, you know, like this person is supposed to be self-isolating, quarantining. And so what is your process for getting the medication to them, right? And then a lot of the times, you know, Tanis wanted us to talk about the pandemic. And, you know, that was something I really noticed a lot of were doctors and pharmacists who were kind of like, it's like, okay, so what's your process for getting that medication to them when they can't leave their home? And the doctor, the prescriber or pharmacist were kind of like, well, what we do is we get them to come to the back door and we wear our mask and our gloves and our protective gear and we get them to wear their mask and then we hand it out to them, you know, but we make sure we're far enough away. And it's like, are you serious? It's like, did you not hear me? Like, okay, but actually the person has been told to self-isolate and quarantine at home by
but I come to a pharmacy every day, which means that I could have to take a bus,
so,
SkyTrain, and then walk by a million people.
Yeah.
But what I'm supposed to do.
And then go to the back doors. So you're asking the person to go. And then the pharmacy is kind of like, well, we don't actually have a delivery system that can deliver controlled medication, so they can't do daily witness, right? So that's another hurdle, right? And it's like, okay, so we have to think about that. We have to find a different delivery service, you know?
Or else at the beginning, when all of a sudden everybody, when the pandemic started, were allowed to be getting carries. We're not going to see their doctors. And everybody, so people start to adjust to that. They're not having to go to a pharmacy every day anymore. They're staying, being able to spend that time that they would normally be commuting to wherever to do other things. Then all of a sudden, the doctors decide, bang, or the college, sorry, the pandemic's not as bad anymore. So people aren't allowed to have those carries. So take them away. It happened, and it happened, and we're able to be there to try and talk through what we're going to do about it, which is one major thing that we actually need to talk about and deal with. This. What are we going to do about this not being able to get carries? Because 94% of people who use opiate maintenance in BC don't get carries. That means 6%. That's like 6 people in BC get to take home their methadone or their Metadol or their morphine. That's a real statistic, and that's fucked up. a program that people are
Yeah.
on, and 94% of the people can't take that medication home, doesn't that tell you there's something fucking wrong with the program?
It's crazy, and it feels like a violation of human rights. It feels like, okay, so I am actually bound to stay here close to my pharmacy so that I can walk 2 blocks there every morning to get my medication that I need to survive, right? And if I'm working, I have to make damn sure that I'm getting there before I have to get to work. And so I have to find a pharmacy that doesn't open at 9 o'clock in the morning. It's got to be earlier than that. Or if I'm taking it later, I've got to find a pharmacy that doesn't close at 4, because I'm not going to make it back. Right?
Yeah, and see, and that's the thing. There are people that have no idea what being on an opiate maintenance could or does involve.
Yeah.
Nobody, who would think that you had to, that there, for you to be able to get out of bed that day, that you would have to get up somewhere, get on a bus, drink a drink, come back, and sometime during that month, see a doctor to ask him to make sure that you can still take that, to do that.
Yeah.
So in other words, somebody else is responsible for whether you're allowed to get out of bed in the morning or not.
It's
in a way that
yeah.
feels comfortable to you. And that's fucking fucked
Yeah.
up.
It feels like
because I chose to put the substance in my body. Exactly. And that's the thing, is BCAPOM has shown and is showing people that it's our decision if we do these things. There are prescriptions and people out there prescribing these things, so there needs to be policy and people that are using them making sure that they're there to be used.
Yeah. Yeah. And the medications, I mean, the studies have shown that the medications, if they're consistently being taken, do reduce the risk of overdose death, right? So, you know, like it's in all of our best interest to try to make sure that we can lower these barriers for people, right? Because
you don't want to see me when I'm not on my drugs.
No.
You don't want to see me when I'm not on my medication.
No, right? I don't.
And that's the thing.
It's like if somebody didn't take their SSRIs for a week, right? If I didn't take my Prozac for a week or something, right? What do you think would happen? I'd probably end up in the psych ward, right?
Or killing somebody.
I need to take it. Yeah.
If something is prescribed, there has to be a policy behind it to make sure that you're not going to have to go through those. And that's the thing with BCAPOM, is that we have learned, people have taught me and us, and just because we have conversations about these things, we have been able to mitigate some of the pains that that people in other places still have to go through.
Yeah, exactly. So ideally we want, you know, a consistent consistent policies, right, across the board, across the province, I mean across the country really, and that you know, these policies are not unfairly oppressing people who are the end users, who are using these medications. The people who are, and I think that's what's changing, I think now a little bit, is that we're starting to involve the patient voice more in the creation process of these processes, because we realize that, I hope, that if you create something for someone, I mean, we're customers, right? We're customers, we're consumers. If you create something for me, but you don't ask me what I want, and you have no idea what I want or need, how successful do you think that product is going to be? Right? If you don't know anything about me and my needs, and you're just going off assumptions, right? Probably it's not going to be very successful. So we really want to, I think the other thing BCAPOM wants to do is we really want to empower people with lived and living experience, people who use drugs, people who are on methadone, people who are on Cadian, to think of themselves as subject matter experts, right? And to be at the decision-making table.
Because we are the experts. And that's the thing that we
Yeah, I know that you guys are a BC-wide organization, and I'm sure you guys have members all over the place. And I'm wondering if you guys are hosting any meetings virtually. Stephanie wants to know if folks who don't live in Vancouver can attend BCAPOM meetings.
Shit, what a good idea.
That is a good idea, and that is not something we have. That's not something we have been doing. We did it at the board level when we had to self-isolate.
Right.
We do have a TV that we could potentially pull people into a member meeting. We could also hold a virtual BCAPOM member meeting at a different time, right? Laura, like
Yeah, why not?
for
You know what?
people that are
Like being more of helping people with their doctors and their pharmacists in a more of a personal level than it has been on a larger group level. And we are a provincial group, so maybe doing a virtual meetings would be a good idea. And see, that's what BCAPOM is for this exact thing, is talking to people about what might help other opiate users.
What do they need?
Have or consume better programs.
Because we could have like a drop-in hour, a drop-in virtual hour where one of us is there, and you know, people from across the province could phone in and chat. You know what I mean? Like there's a lot of,
during our BCAPOM membership meeting time, there could be could be a virtual meeting.
It could be. It could be. The only thing I noticed with during the pandemic with mixing in person with virtual is that I did find that sometimes the people who are virtual sort of felt a little bit out of, not quite in the, not quite because you're not there, because they're not there in person, right? So there's a lot of sort of talk and there's a lot of connection that's going on in person that I think virtually sometimes you can miss out on, right? So I mean, that's just one of the things I noticed, but I would love to, you know, talk about this more and try to develop something that's going to work for folks and help them feel more connected, right?
Mm-hmm.
It's something we can, I think we can prioritize in the new year for sure. So, you know, like one of the things I mentioned was the difficulty of getting people together during a pandemic when people have to self-isolate and be social distancing. One of the ways, so that really impacted our group, and it's still impacting our group. So, you know, it has ripple effects. It makes waves, right? Like, I think we're going to be feeling the effects of the pandemic, you know, for years to come, right? So, and there's also lessons to be learned. So there's opportunities that came up as well as things that we weren't able to do as well. So Laura,
okay,
what about the COVID-19 pandemic? Like, how did the rollout, the pandemic and the rollout of safer supply and the risk mitigation guidelines, how did that impact BCAPOM, right? What did we learn from that and what came out of that?
So to me, what we learned is that that they're not prescribing safe supply in a way that we would. And the other thing is that I learned how it's impacted BCAPOM is that we have been so flooded with people asking for help to save their lives. It's what it's done is shown me how many people are dying.
Yeah.
And that there are still 3 times the amount of people dying from an opiate overdose than there is from the COVID pandemic. And we still are not getting the recognition that we need. I'm not saying recognition meaning award recognition. I'm meaning attention that there is a fucking problem.
Medical need.
And that people are.
Yeah.
And
even if they haven't died yet, it's like people are walking around like a corpse. You know what I mean? It's like I'm walking around, but I am not here. I've definitely had those experiences this year where it's like I don't feel like a person, you know?
Well, the thing is that it's not now, right? I've said it to you before, is that it's not if I'm going to die, it's when. If they do not give if I do not get onto a proper safe non-illicit opiate, I am going to die. It's not it's not if I will, it's when. And the numbers say it. You can't keep a group of people with 4 of them dying a day and not know that you will be one of those 4 people if the people do not understand or get the fact that we need something different.
Yeah.
And that's what the pandemic has shown me, that we don't have enough control over our own lives, and that people are not, they're not listening. They're not, it's NIMBYism, not in my backyard, it's not my problem. But when there are 4 people a day dying, then you can't tell me that you're not going to be affected by it in some way.
It's everyone's problem. It's everyone's problem, right? Because it's going to touch everybody in a way, right? Statistically, you're right. You know, who is it going to be? Is it going to be me? Is it going to be somebody close to me? Right?
Yeah.
So yeah, totally.
It's what's important with BCAPOM is that that's because with the education that we're able to give people, it's saving people's lives. It's getting them connected to an opiate replacement so that they don't stay at home and overdose alone. BCAPOM is not just about, it's about connecting people with life-saving information. So telling them, showing them that there's a different group about something different here, or that there's somebody that'll walk down this road with them. To me, it's about saving somebody's life. If there's one life that I saved just from that I talked to, or a doctor's appointment I go to, then it's worth it.
Yeah.
And that's what it's about. BCAPOM is about saving lives.
And I've learned, you know, if you're a person who uses drugs, if you are a person who has used drugs and you're in the pharmacare system, as you know, being on opiate replacement or whatever, if you're going to the emergency, if you're going to see a doctor, do not go alone. You know, try not to go alone. Try to bring at least, if not, you know, a family member or a friend, ideally an advocate, you know, or have them on speed dial. You know, I was in a situation where I was in the hospital and I had my phone was dying, you know, and I had I had one call that I could make, maybe, you know, and that's not a good situation to be in for a person who uses drugs, because often what will happen, and I'm sure you guys are aware of this, because I'm sure it's happened to all of us, is that the prescribers, the nurses, the triage People, they will treat us differently than they would if there was someone else there, right? If Laura was there with her Providence Health badge, they are going to be singing a different song, you know.
And see, that's what I was saying earlier, is that I'm glad that I'm able to, that because of what I do, I'm able to help somebody more, but it's sad that it has to be that way. That having a badge that says Providence Healthcare on it will change the decision whether I am able to help you get a better medication than what you walked in on.
Yeah.
But I can sometimes.
Yeah. And sometimes what I feel like I'm doing is I'm translating. Like I'm like the translator between the patient and their doctor. Like, because, and it's like, oh, it was a miscommunication. Miscommunications can happen so easily, and I feel like people in the medical profession are not attuned to that enough, right? Like, you have to be really careful about how you show up and present yourself to someone else, because, you know, the way you look at them, the way you talk to them, the tone that you use, you can lose that person in an instant. They are gone. They will not stay, right? And that means they could die, right?
Yeah.
So
when we I found out that it could be 120 days before a complaint is even processed. So that means if there's something wrong that happens to you with a doctor that you feel like you need to make a complaint about, or you need to bring light to, it could be 120 days before anything even happens. But with us being with BCAPOM being we're able to help you so that maybe you don't even have to, that you won't have to do that. You don't have to make a complaint. We're able to deal with it for you first. We're able to walk beside you in that doctor's office and give you the power to say, I don't think this is not the program that I want to be on, and this is not working. I want this. And we walk out of that office or get off that phone with that prescription in hand, ready for that person to take.
Yeah. And if there is a complaint, and if your rights have been violated, because we have had people who have, you know, we can stand with you, right? We can help you write your complaint. You know, it's your complaint, but we can help you with the process, right? And we can stand with you, because it's a very scary thing to report, right? Especially your doctor, who has so much power over you.
Yeah, and that's the thing, is that one thing is you're not alone. We'll walk beside you. We'll stand beside you, and we'll help you if you need me. If you need me to help you to remember you have an appointment that day, then you know what, I'm willing to do that. I'll help you to get there, but you have to help me. You have to help me get you there. Because of BCAPOM, I've been able to get a job with the BCCSU, which is the BC Center on Substance Use, as an advocacy navigator for opiate replacement therapies, which means that I will call a doctor for you on your behalf to speak to them about your prescription and get a better one for you. That's what I've been able to do with BCAPOM, and why I think it's important. Yeah.
It is, yeah. So looking forward, Laura, like what's next for our group? What's next for BCAPOM? How do you see the group expanding and evolving, you know?
So what I hope is next is that we do an extreme campaign on people's access to carries. So for people who are listening that don't know what I'm talking about, what a carry is people being able to have their medication and take it home with them without having to go and stand in a place every day and drink a drink or take a pill or do an injection in front of people that may not understand what's going on, may not know, and look at you weird or make you feel uncomfortable. Or,
You're
and
in
that,
public.
and that's what I see. What I also see is I see us trying to empower people in places like Nova Scotia to start groups like BCAPOM to give people empowerment, to say like, because I choose to consume drugs does not mean that I'm a bad person.
No.
Or doesn't mean I do bad things. It means that I like the way it feels, and I would like that. And to me, that's what I'd like to see.
Yeah, me too.
Help it normalize the drug use or the drug consuming that we're on, and make it so that the medications that are available to us are given to everybody the same as they want, and not just because you know or because you have a badge that says you work for a hospital. It's because you are you as a fucking person.
You're
and
a
because
human.
It's your human right, not
and it's
your
healthcare.
Not your it's not a privilege.
It's healthcare. It's supposed to be Canada. It's supposed to be free healthcare. You know? I totally agree with you. And what I would like to see is that, like, you know what? Maybe my thing is like, okay, fine. Maybe I'm gonna be on methadone, Metadol D for the rest of my life, right? And maybe that helps me, because then I'm not always in resistance, and I'm not always thinking about, okay, when am I going to be able to do this taper, right? Because anybody who's switched medications knows how hard that is on your body, your mind, your spirit, right? If you survive it, you know, you're lucky, right? So maybe I don't want to go through that again. Maybe if I have found something that works for me, I'm going to stick with it. I have acceptance around that. I'm not in resistance. That's powerful, right? And I want to see more people that are in acceptance about it. You know, it's just medication.
I hope that one day that I'm able to get to a level again where I'm able to accept it, and where I'm not still struggling every day to feel just normal, to feel like that there's not something I have to take every day. It's that I wake up in the morning and I don't know anything different. I don't know that I have to go to a pharmacy, or I don't. It's just that it's just what I do, and that you just made me so happy but so sad, because I was, to me, a lot, before they switched us from methadone to methadose, I'd been clean off opiates for 5.5 years, and then a government made a decision about a medication I was on that turned me back to sticking a needle into my arm and overdosing 10 plus times.
Yeah.
Oh, Howard's dogs is asking for him in here.
Okay. In regards to the time we have left, we have a few questions from the audience here. Christine Sandow wants to know how she can connect clients with the association, and any tips on encouraging clients to reach out to your association.
BCAPOM has a Facebook page, and on there there's phone numbers and stuff, I think, isn't it? Yes, there's if you go onto the British Columbia, there's a Facebook page that you can go onto, which will connect you with phone numbers, with emails, those things, and we try to get back to you as soon as possible, because we know that something to do with an opiate replacement is not something that you can't wait a week, or you can't wait it's immediate. It's like, as in the minute, you need to do it now. And one thing is that we need more people that are willing to speak up for people, so that that can happen, because there's only a few people that have that ability, then it's not then it's not
Yeah.
very sustainable. It's really hard. And that's why I'm really glad that Raya is here now and that I have the BCAPOM group, because they've empowered me to be able to connect with you.
Yeah. And I think like we have the Facebook group. It's maybe not, you know, the most active, but it does have our contact information on it. If you send us a message through there, we will get it. I'm an admin, Laura's an admin. We are planning, you know, for a little website, you know, in the future. You know, that's one of our things, and we do want to be more accessible. We do want our contact information to be more accessible. We do have a number, right? And we've got emails. So Tanis, you can share a lot of that information with
Yeah,
the panelists, right?
Yeah, I just shared the
Yeah.
Facebook page link, as well as the phone number. And on
Mhm.
the Facebook, I see that Laura, your email is up there. Should I share that as well?
Oh yeah, yep, for sure. And if Raya's is not, then we could probably probably update it so that it's on there.
I'll add that on too.
Yeah, you can add my email
Okay.
too. Yeah.
Okay, perfect.
There's one more question I would like to touch on. Do you guys focus on like peer-to-peer support while people are detoxing or adjusting to different prescribed opiates? How do you manage that type of support?
So that's actually one thing that is good, is better now that Raya is part of the group, because she has been she has had more recent and more experience with that aspect of opiate replacement maintenance. If you don't, sorry, I guess I should have asked if I could say it. No, but with that, because myself, I have accepted that I may never ever come off the medication, and I'm okay with that. So I don't know exactly how exactly to guide somebody in going into a recovery or an abstinence or a you know, kind of aspect. And I think that Raya can, or somebody else in the group, we can lead you into that.
Or not even just abstinence, but just switching from one medication to another. So like switching from Suboxone to Metadol D. That seemed to be something that there wasn't really much guidance around. You know, my doctors didn't really seem to know much about what I should expect. Right. So and I've been on Suboxone for like 4 or 5 years. So what does that look like? What do I need? Right. And then I had to do that. I had to navigate that process at home. Right. And then when I would go and see Laura, who's also a friend of mine, you know, a very good friend of mine, and then also the other BCAPOM members, I was able to share with them and talk about what I was going through. You know, Garth Mullins gave me a lot of really good advice, and it was gentle advice. It wasn't like, you should do this, you know. It was like, you know, have you thought about this? You know, this might be a possibility. So I do think that there's definitely a need for, that's a big gap, right? In terms of when people want to switch medications, or when people want to go back onto their medication after a period of using. That can be really difficult. And I don't think that's something that the healthcare system has not addressed yet. So that's something that kind of like we want to work on in the new year, right?
Yeah, and having people that know how we're feeling and what we're going through makes it much easier to go through those things. So people who are to go through a detox, or maybe switch to different medication, we'll be able to tell you what to expect, or somebody that we know or something that we've learned will be able to tell you what you're going to go through, or what's a possibility, and that can help you to go through it. And I think that's how we support you, is by putting you in touch with somebody who is going through the same thing or has gone through the same thing.
Yeah. So reach out to us, right? Use those contacts, right? Reach out to us.
Yeah, it sounds like you guys really tailor your advocacy to who you're working with, and that's
Totally.
super important, just because everybody's struggle is so different.
Okay. Well, that's the thing. That's what I've learned, is everybody's so different. But
yeah.
Okay. If there are no last minute questions from the audience, or no, do you guys have any few comments you want to end on before we wrap up?
Just that it's a tradition at the end of our meetings, you know, with VANDU and BCAPOM, to have a moment of silence for all the people that we've lost to the overdose crisis, to, you know, any type of passing, and if there's any dedications, right now would be the time. So so this moment of silence will be for them and anybody that we may have missed. All my relations. Thanks, guys. I think I'm done.
Relations.
All my relations.
Thank you.
Thank you so much to our presenters and to everybody who joined today, and we hope that you have a lovely rest of your day.
Thanks so much, everyone.